SAGES Stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode. And enjoy the show. All right, so welcome to SAGES Stories, everyone, where we shine the light on some of SAGES' most impactful leaders. I'm Dr. Jenny Shao from Ann Arbor, Michigan.
And I'm Dr. Kevin El-Hayek, coming to you from Cleveland, Ohio.
So today's guest is a surgeon, educator, research, Jedi, possible Sith Lord, and an anime aficionado, and we mean that part very literally. He's a professor of surgery at the University of New Mexico and the chair of the SAGES Ergonomics Task Force. He's also co-editor of the SAGES Biliary Manual and one of the most fascinating people in the society. So with that, welcome Dr. Edward Auyang. Welcome to SAGES Stories.
Thank you for having me.
So Jenny prepared a nice lineup of questions for you. I hope you're ready for them. It won't be oral board format like I warned you. So you can let your guard down because you look like you're ready to answer a question on necrotizing pancreatitis.
Well, with that introduction, I'm already like, well, can I use the force to, change the questions in my favor or something like that? I don't know what's coming my way.
I know. I think this is the best part. I feel like Kevin and I are really intimidating people. So usually we really put people on edge when we do these podcasts.
We go for the jugular.
All right, let's do it.
All right. Well, maybe to start off, Ed, do you want to give us a bio that you tell somebody at a party, not your CV version? Tell us a little bit about yourself, and we'll start from there.
Sure, like including like my background and things like that.
Yeah, maybe the party version, the really fun version where
The
you use the
party
force.
version. Well, let's see here. Just, I guess, a little bit about where I'm from. I'm originally actually from the East Coast, born outside of Philadelphia. My family moved to Cincinnati, Ohio, right before I started high school. Went back to the East Coast. Did my undergrad at Hopkins, studying biomedical engineering and computer science. Went back to Cincinnati, where I did my master's in biomechanics and ergonomics, environmental occupational health, and then went to medical school at the Ohio State University in Columbus. Go Bucks. Went to Northwestern in Chicago, did my residency there, and completed that, and then headed off to Seattle, where I did my fellowship in minimally invasive foregut surgery. And then I took the job here at the University of New Mexico in 2012, and I've been here ever since. So that's kind of a little about who I am and what my travels are. I guess academically, clinically, my interests are related primarily to benign diseases of the stomach and esophagus. I do a lot of anti-reflux, redo foregut surgery. I like gallbladder surgery, still do some hernias. One point, I was also in-house trauma surgeon for about 8 years at my institution. So a running joke was, yeah, one day I get to fix a stab wound to the ventricle. The next day I'm doing somebody's redo paraesophageal. But it was a lot of fun. Fortunately, I guess I've senioritized out of it. We've hired more faculty, but I really enjoyed that part of my career as well. Um, that's, I guess,
Did you let your ATLS lapse?
I think my ATL is still active, and I still actually teach stop the bleed and things like that. So, and every now and then, if too many of the trauma surgeons are out of town on, at East or AAST, I'll still pinch hit every now and then. But yeah.
That's awesome. I love your varied practice. I think you're the first person to tell me that they love gallbladder surgery. I feel like universally, unless you're a hepatobiliary
gallbladder
surgeon,
surgery.
everyone's always
Gallbladder
like,
surgery
"Oh,
is great.
I love
really?
gallbladder
Oh,
surgery.
okay.
I love it.
Maybe it's like as a non-HPV surgeon, I'm always like, oh, gallbladders, so much to lose and not much to gain.
Not
Like
much to
nobody ever
gain.
congratulates you on doing a good gallbladder surgery, which is like 99% of them. But then every once in a while, everyone's like, why did you mess that one up? So I don't know.
That's fair. You can't. It's hard to get congratulations after a gallbladder. That's for sure.
That's very true. But the anatomy is so fun, and having mentors who were, developing the techniques for laparoscopic cholecystectomy way back when. I mean, it was a big influence in terms of what my personal clinical practice is and, kind of my interests and everything like that. So, yeah.
Why don't you tell us a little about your, some things that you're interested in outside of medicine?
Yeah, well, I think I've been accused of having way too many hobbies, and you all probably have either experienced it firsthand or seen it through my random social media posts. So it's like, where do we even begin with the hobby list?
It's not a 2 hour episode, so
Okay,
you
okay. I was like,
gotta,
yeah,
yeah.
like, how much time do you want me to spend on this? Okay. Well, today is May the 5th, so it's Revenge of the Sith or Revenge of the Fifth, however you want to pronounce it. So, I am, of course, a
We
huge
picked this
Star
day on
Wars fan.
purpose.
Yeah,
Huh?
we
You picked
did.
this
We
day on
did.
purpose, yeah. So,
Actually, we should have done May 4th
We
because then
should
it
have
would
been
have been
done May
May
the
the
4th.
4th be
Yeah.
with, oh my God,
But
that's so
we're gonna
crazy. I
find
can't believe
out
I just said
later.
that.
We're gonna find out later, we're gonna ask you a little bit specific more about this, but we'll find out which day would be better,
fair
actually.
enough, fair enough. But this is the May, so that's okay. So I am a huge Star Wars fan. I mean, I remember seeing the first movie in a drive-in movie theater way back in 1977. That's one of my first childhood memories. Yes, I guess I am older than I probably look. But Star
Yeah.
Wars is a big, part of my hobbies. I enjoy collecting Star Wars memorabilia. I play in a I play a Star Wars tabletop miniatures game and had to cut my Sages short this year to go compete at Worlds, which I've done for about 4 years in a row now. So it's
Wait,
a
what is that? Sorry, I have no
yeah.
idea what it is.
Yeah, people are like, what in the world is that? Well, it's so a tabletop miniatures game. It's not like esports or something like that. It's not a video game, but it's a game where you actually have physical models and think of it as chess, but with Star Wars ships and you're rolling dice and you're dog fighting with each other. So it's a model-based, physically moving things around strategy type game. So it is a hobby I play somewhat regularly. I host local tournaments here in Albuquerque, play with a local gaming group, and again, I've attended tournaments throughout the country over the last probably 8 to 9 years now. So that is definitely a hobby of mine that I enjoy. It's a fantastic community, fun game. So keeping that game alive. A lot of people know me as the Sage's whiskey guy and running the Great Whiskeys of Surgery. I've
Yeah.
enjoyed whiskeys and understanding the whole distillery process and the culture and history that comes around from different regions. So I'm a collector, but also a connoisseur and really enjoy sharing my experiences and knowledge with other people. Try hosting the events at variety of meetings, whether it's at Sages, the college, anything I attend. It's a great opportunity to meet new people and share a common hobby. So that all kind of started really about during the time of COVID, I think, when people weren't able to interact as much, and we would have online little, Zoom happy hours, and then it's grown into a hey, when's the next meeting and where are we getting together and things like that. So that's been a hobby of mine. I enjoy playing music. I grew up playing piano and then transitioned to violin. Somewhere along the way, I played a, trumpet, I think, for a year, then picked up the guitar at the end of high school. I've had a chance to play with some of the other Sages members at the sing-off, which has been a lot of fun. And I'm a big electric guitar, rock, metal music fan. So another one of my multiple hobbies. Geez, I could keep going. What else? What else do I do?
How do you have time for all these hobbies? I
I
feel
know. I
like
was wondering,
sometimes
like all the
I
Yeah.
24
was like,
hours in
how
a
do you have
day.
time
It's
for all of
like,
this?
Well,
yeah,
I've always had the philosophy of work hard, play harder. So it's like, yeah, it's like when you need to put in the time for work, really, 110% at it. But I've always been somebody who's enjoyed doing other things to just relax my mind, relax my body, and just kind of not think about work-related things. And this has been going on since, high school and earlier. It just came naturally to me. I always found an outlet to find relaxation. Some of them have helped with my career, and others have just been completely unrelated. And, just purposefully taking that dedicated time, I think means a lot. Sometimes it's easier to do on busy and eat lighter weeks than others. Sometimes it's like, yeah, I haven't played probably my guitar in a couple months now, but I'll find an hour here to play a game for with some of my local friends or something like that. So I think you have to be a little bit, purposeful about it sometimes, and you can always sneak in little pieces of time. I know a lot of people enjoy music, for example, and you don't
Mm.
necessarily need to just put on an album and listen to it for an hour straight. But hey, if you're going between locations in your hospital and you want to put an AirPod in and just kind of listen to a couple tunes along the way just to kind of reset yourself, I mean, you find ways to make it happen. And I think it's just come naturally. And at times I'm like, hey, you know what? I do need this afternoon for myself or something else like that. So,
That's
so that's how
awesome.
I do it. But I guess if you talk to my wife, she'd probably be like, yeah, he's got way too many hobbies. He needs to quit a few.
I think
No, I think it's
at one point we're definitely going to have a like a spouse call-in moment in this on these podcasts to kind of see, to see how these various activities really impact the person and, and their families because yeah, when you hear that list, it is I like how you're threading the needle and you say like you're just kind of as you're walking through and but it seems like I agree. I don't know how you find the time to do it all.
But I think it's really important to hear for probably our trainees and some of our students because sometimes I think in medicine you get so caught up in being in medicine that you always say, oh, I'll do this after med school, I'll do this after residency, I'll do this after fellowship, I'll do it after I become a first year attending, and then you just keep putting things off. So I think it's also like a good reminder to people that sometimes you don't want life to pass you by, and you just also got to do the things that you love while also being a physician. And sometimes I think it's hard to remember that in the moment.
Yeah, well, I think like during residency, for example, yeah, I didn't have time to do all the things I mentioned now, but I did have my guitar amp in my apartment. And even if you're, at the hospital at 5 a.m. and you're getting back at 7, 8 p.m., sometimes after grabbing a bite, I would just plug in and just play for 15 minutes. And that was good enough for me to just kind of, throw some riffs down or something like that. And again, it doesn't take a whole lot of time. And if you make it accessible to yourself and tell yourself, hey, yeah, a little bit of time here or there is enough, then I mean, it really helped me out. I probably played more guitar actually in residency from a, frequency per week, but it'd just be for short little bursts here and there than I actually do now. Now I'm more of the, well, let's see here. How many songs can I try to learn? Or I'm going to spend, half an hour to an hour trying to learn, a new tune or something like that. Whereas before it's like, oh, just sit down, jam for a little while and call it quits. So,
It's awesome.
yeah.
All right, so we're gonna go back because number one, biomedical engineering to a master's in ergonomics to surgery.
Yeah.
It's not exactly a straight line, and you did allude to the fact that you were at a drive-through in 1977, which was before I
Drive
was
in. The
born.
drive-throughs where you
Drive it,
pick at
drive
McDonald's
in. Yeah, yeah, the drive in. Yeah, that's right. The drive in. Yeah, not the drive-through. The drive in, which was actually before I was born. Which if there was video, people would look at the two squares and go, "There's no way this guy is older than you, Kevin." And so we know that your journey was not a straight line just by that alone. So walk us through that biomedical engineering to masters in ergonomics
Sure,
and
sure.
surgery.
So I think when I first went to undergrad, I was very, again, like I said, biomedical engineering, computer science. I think at one point in time, I was like, I'm going to be some engineer working for industry. I was like, maybe I'll build Terminators or something like that. Terminator 2 came out when I was in high school, and that'll also probably help, you know, date
I
my
love the pop culture references.
stuff
This
like
is
that.
really
Yeah, yeah, I
good.
just gotta throw those in there. I mean, that's the thing. I'm just full of like random facts also, which people are like, how do you just absorb that stuff? I don't know. It just finds a place in my brain. But nevertheless, I mean, biomedical engineering wasn't really a big major at the time. I mean, there were a lot of traditional engineering fields, and there were some universities that had BME, but most of them were based out of a traditional engineering department. I was lucky to find an institution that had it and had had it for a while, and it really allowed me to kind of explore both like the physics and engineering sides and kind of apply it to, you know, modern healthcare needs. So a lot of what I did in undergrad was medical imaging work. So again, my minor was computer science, and that was kind of my focus. So back in the day, I was helping to write software that would merge PET scans with MRIs of the brain to actually help tumor localization and things like that. So it's like, hey, this is again, this is early mid 90s. And, we didn't have super high res MRI, high res CAT scans. And people were like, well, how can we help try to localize tumors on imaging? Well, we need to fuse two different image formats together. So it was writing code to take resolutions of two different images and merging them together. One of my other courses was like, how can we locate instruments in three-dimensional space? So actually, I remember going to Dr. Ben Carson, pediatric neurosurgeon at Hopkins, going to his OR when he was relatively early in his career and watching him do surgery. But we were like, how do we track where is his drill at? Where is this probe at so that eventually one day we could fuse a CT scan and then onlay that with the image. And it's basically turned into modern day stealth technology for neurosurgery. And this is, 30 years ago, but we didn't know it at the time. We were just a bunch of students just trying to solve a problem. Like, how can you locate a piece of equipment in space? It's like, wow, that sounds like an interesting topic. And of course, computing wasn't at the level that we have it now. I mean, the computers, even the workstations we had at the time, probably have less processing capability than your current smartphone. But, it was a lot of hard coding. It was a lot of problem solving. It was just really interesting to me. But I think the thing that I realized is that, yes, I'm not as good at coding as a lot of my colleagues were. Writing in C++ or assembly or something like that is like another language. And some people are just really good at it. And I found that, hey, I've got to do a lot more debugging. This is before a lot of the modern, software writing programs. We had to write every single punctuation mark, every single, apostrophe, parentheses, and if you were off by one, your program would not compile. And for me, it just wasn't as natural as a lot of my colleagues. So I'm like, well, what can I do that's a little bit more applied, that's not necessarily just sitting in front of a computer writing code all day long? So that's kind of what headed me in the direction of doing my master's. So the program I had enrolled in was environmental occupational health. It was at the University of Cincinnati, and it was essentially like a public health program. So a lot of it was biostatistics and epidemiology and things like that. But specifically within this department, they had a group that was focused on biomechanics and ergonomics, and it was looking at specifically work site injuries. So I was trained to become an OSHA inspector. I learned the Code of Federal Regulations, and if an OSHA inspector goes into a job site, how does a company become non-compliant and things like that? And we'd go around looking at health hazard evaluations. So whether it's occupational exposures to inhaled substances, to hot and cold, to slip, trip, fall hazards. I mean, you name it, we learned how to do all those sorts of things. I mean, I learned how to create HVAC units based off of a room's shape and size and what kind of push-pull mechanism. So it's like, again, it's kind of out there, but it was applying engineering principles and physics to health. And my sort of specific subject was looking at kids who had lead exposure and looking at their neuromotor function. So their ability to maintain balance, their gait patterns, fine gross neurocognitive function. And we would analyze that based off of their blood lead levels before and after chelation therapy to see if chelation therapy actually had any sort of reversing effects on their balance and their gait and things like that. And I was like, wow, this is actually really cool. It did show an effect, and we published on that. But just kind of understanding human factors and how the body responds to different environments and things that affect it, I thought was really interesting. And again, here I am. It's like, okay, now it's a little bit more applied engineering, still programming, but not as much because we were using developed software. And, we were taking essentially the reflective markers that they would place on athletes to create video games at the time. We were doing that to workers and recreating work environments and looking at, angles and postures and repetitive stress and everything. I was like, wow, this is, pretty cool stuff. Um, it was fun working with the kids, like the patient population we recruited from Cincinnati Children's Hospital, and we got to, see them before and after treatment and got to see an effect. I was like, wow, that's really pretty fun. Maybe I should actually head in the medical direction. So worked for a year in my advisor's lab, applied to medical school, thinking I was going to do pediatrics because I just really love that patient population. And yes, I'm an adult general surgeon. So obviously that changed during medical school. And I think what had happened there was after the first year of medical school, there was an opportunity to work with the Ohio Supercomputing Center. They were developing a virtual surgical simulator for otolaryngology. So, like, hey, we want to take high resolution CT scan and create a force feedback with sound, haptics, virtual simulator to do mastoidectomy of the temporal bone. I'm like, well, I've got computer science experience, I got programming experience. This sounds kind of interesting. Hopped on that project. And guess what? There were people who could actually write the codes. I didn't have to do any coding, but they're like, since you're a medical student, why don't you interact with the surgeons, kind of see how they do the operations in the operating room, and then bring it back to us so we could try to make an accurate simulator. So that was a really cool project that I got involved with. I think one of the other things at the time was the first version of DaVinci had just come out. This was 2000. And they needed naive test subjects to say, hey, what's learning curves for things like passing, a needle through a loop and picking up beans and moving back and forth. So of course, first year medical student, you're considered naive. So I was a test subject and got to play around with that. But I think that's kind of what got me interested in surgery more specifically. I mean, I had great mentors at Ohio State, some of which have been, former presidents of SAGES and really been influential in the community. But that kind of showed me it's like, hey, this is what technology can do. This is something that didn't exist 5 years prior that was starting to pick up traction. And of course, now we are 2026 and robots are everywhere and we've got dual consoles and all these other things. So again, the technology side of it, I think really attracted me to surgery between, the disease processes, but also knowing that technology and industry was a way to make medicine different and to improve it in a real-time fashion. I mean, we have things now that we clearly didn't have 10 years ago, 5 years ago, 20 years ago, 30 years ago. And, who knows what's going to happen in the next 5 to 10 years also. So I guess that's kind of what brought me to the point where I ended up in surgery and minimally invasive surgery.
Yeah, no, I love your story because I feel like a lot of times, when we talk to pioneers in the field of minimally invasive surgery, we're talking a lot about laparoscopy, which is, a different kind of technology. But I love that you're talking so much about coding and some of this other side and technology that we don't often talk about as much. And I think it's kind of coming more to the forefront now with everything that's happening with digital surgery and AI and robotics. But you sound kind of like the OG person, you were doing it
Well,
way back when. But yeah, and I also love your take on ergonomics because I think sometimes as surgeons, we get this really tunnel view of what ergonomics actually is. And I love how you're framing it in the perspective of like occupational health. And so, can you tell us a little bit more about that? I mean, in your role now as the chair of the ergonomics task force, like what are some of the things that you're thinking about, some big picture goals that you may have for the task force? And just kind of want to hear your thoughts about this topic in general.
yeah, I mean, again, ergonomics has been something that's been around for years and years, and we've just kind of ignored it in our own field just because of, sort of government jurisdiction over what we do. I think we've talked about this in some other episodes, periods in the past, but you don't see OSHA showing up inside of your operating room, right? They don't really, or they're not looking at that. They may be looking at the people building your new operating room or renovating the buildings around the hospital, but they don't really focus on the providers and what we have to do in our work environment. And it's interesting because just from, my past experience and everything, I would adjust and modify the way I set up my instrumentation, the way that, my monitors are, my heights and everything, just because it came naturally and that was part of it. And um, and it's finally something that people are paying attention to now. I mean, obviously, Jenny, you're doing a lot of work with, the Society of Surgical Ergonomics, and it's like finally people are starting to recognize that it is a problem and that we've been ignoring it within our profession for so long. I mean, it's kind of one of those, oh, just suck it up and, tough it out sort of thing. But, the thing that also probably has helped me, want to push this forward is my own mentors who've had to have surgery to deal with musculoskeletal injuries not related to sports or something else, but from operating in minimally invasive surgery back in the 90s, early 2000s when nobody cared about these things and people just dealt with it and seeing, 20, 30 years later that it's actually causing long-term effects. So I think part of it is for our own profession, we're still actually in a very early phase compared to a lot of other industries that have been doing this for 30 or 40 years. So I think it's, first of all, it's recognition that there is a problem. I think it's looking at the frequency and having people willing to report their injuries and report the stress and strain that they're having, because without the data, it's hard to make any changes.
What you
And
mean surgeons aren't really the most straightforward or
Yeah, I mean,
forthcoming when it comes to
you
workplace
mean we
injury?
don't, yeah,
oh, never. I
exactly.
mean, everything is perfect, right?
Right.
Like
Yeah.
everything is exactly the way we want it and everything else. But, when it comes to our own things, nobody wants to say that, they're feeling something for whether it's fear of showing some kind of weakness or whatever else. But I think it's like it's a real problem, and we need to be willing to have those stories. There are surgeons now who are going out and sharing their experiences of how
Hmm.
they've had severe physical trauma from repetitive stress that's affected their careers. And, as you talk to people, it's like people talk about it on the side, but nobody really wants to talk about it and really document that it's happening. So I think the thing that we need to do now is to really, you know, be willing to um, show quantitatively that there is an issue, because we know it happens in every other um, profession that requires repetitive motions. And then once we have clear quantitative evidence, then it's where do we go from here? And it's dovetailing with the government, it's dovetailing with industry, it's dovetailing with the local environment to try to do the things that we can to mitigate and reduce the potentials for stress. I mean, you can't be in a completely stress-free environment just because it's manual work.
It's a stressful job.
Yes, yeah, both mentally and physically.
Yeah.
So, there's always going to be some aspect of it until, somebody can just, I guess, plug you in and you just sit there like in the Matrix or something and you're able to do everything without moving anything, and which is
I
probably
can't
also
wait
not
for
good.
that.
That's
No,
not good for your body also, right?
that's going to be awesome.
You're
When we
probably
can
gonna,
do that, that's going to be fantastic.
right. I
Well, it's
mean, maybe in
it's
the
funny
future.
because I actually didn't know this about you. This is so funny because I've known you obviously since 2011 when we were co-fellows together, and the mic drop moment that you did in Long Beach was part of the impetus for getting you on today, because I remember it was the last day of the meeting because you were in jeans and probably an anime shirt or some kind of rock shirt. It was perfect. Ed definitely takes the casual Saturday to heart. I mean, if you see Ed on the last day of Sages, you'll know. You didn't see him this year because he was gone, but in
I was
Long
playing
Beach
in a Star Wars
he was
tournament.
playing in a Star Wars tournament. But in Long Beach, you said something that I mean, you got up there. It was at the ergonomics session, and you're like, like everybody was talking about how, I remember very clearly, like how robotics has totally like removed the ergonomic problem from laparoscopy, and you just like walked up there and you're like, actually I did this for a living, and it was so perfectly placed, and I was like, why are you not up there? And I know you're giving other people a chance, but this was actually a couple years after I herniated a disc in my low back, and I think part of it was my posture in robotic surgery. Another part was that I probably needed to lose about 20 pounds, but that there's a lot that goes into the repetitive stress, and so you got to fix the things on your end, and then the things that you can fix um, in the OR are also in your control.
Yep.
So if you were to drill down one practical thing, something a surgeon could do tomorrow,
Mhm.
who's listening, based on what you know about surgical ergonomics, what
Mhm.
would it be?
I think the first thing that I would say that anybody can do, whether you're an open surgeon, laparoscopic surgeon, robotic surgeon, whatever your technique, and actually any sort of proceduralist, this could even go for, endoscopists and everything, is that If you are spending too much time in the static posture, it's going to cause musculoskeletal stress. So I try to make a mental note of every 30 minutes or so in the operating room. I will actually pause our whole team as long as it's a place where it's safe to do so and just say, hey, you know what? We're just going to take a little ergonomics break. Refocus your eyes around the room, stretch out a little bit. Everybody just kind of loosen up, refocus. Helps you get out of tunnel vision, especially if you are in a 5-hour case and you're really focusing on some redo hiatal and like, okay, where's the aorta, where's the cava, where's these things, and it allows you to just kind of regroup. And it's good for everybody because if you do it as the surgeon leader and you're telling all your other staff to do so, then it's kind of like, I mean, it shows that first of all, you're caring for your whole team. Obviously, you can't do everything by yourself. And for your surgical tech who's standing there for that amount of time and everybody else and your residents or your fellows or your students, by taking that little break, even if it's for 30 seconds, I think is a huge thing. It allows your body to reset. So I think that's something that everybody can do. It doesn't require any cost, no materials, nothing. It just requires 30 to 60 seconds of time, which adds nothing in the grand scheme of things. So I'd say that's the first thing I would actually suggest.
That's great advice.
Yeah.
Yeah, I love that. It's that concept of micro breaks, right? I think there's some
Yeah.
really good research and data out there to show that micro breaks actually can decrease length of time in the operating room. It can help you refocus and it can help hopefully prevent injuries. But yeah, I love that you got up and said that because I think one of the most common misconceptions about robotic surgery is that it's going to fix all the ergonomic issues. But I totally agree with you, Ed. I think it probably just introduces new issues because your repetitive motion are just different, right? So your strain is probably just distributed differently versus like traditional laparoscopic or open surgery. But I don't think it necessarily takes anything completely away.
Yeah, I mean,
Um,
a sitting posture is not necessarily better than a standing posture. I mean, you're putting more strain on your L5S1 joint, and especially if you're leaning forward the whole time. So it's like, yes,
The
you're taking,
joints that herniated in me. So
there you
yes.
go. I mean,
you
exactly.
were
It's like
sitting
you're
too much
taking
during
stress
surgery,
off
Kevin.
your.
I was sitting too much and needed to lose 20 pounds. But again,
Like I think the thing that I brought up, Kevin, when you're talking about that one session at Sages, I was like, you know what? Long haul truck drivers who, sit for long periods of time have a higher rate of hemorrhoids than
yeah, that's
anybody
right.
else.
I think I
So
also
I'm just
remember that
saying,
comment. Yes,
the
I think I remember
colorectal
that
surgeons
comment.
are probably pretty happy with all the surgeons doing robotics. You sit there for too long, that's not necessarily a good thing either. So
I
we
remember
may
you saying
find
that as well.
nobody's self-reporting that data. Maybe that'd be
No,
an
we're not
interesting
gonna get into all that. We're not gonna get into
that
all
may be
that.
an interesting survey to send out to the membership there. But yeah, again, it's like yes, you're trading one posture for another. So you just need to figure out ways to adapt and ways to relieve that at intervals.
Yeah. Well, so the other thing I kind of wanted to ask you about is, when most people talk about ergonomics, we tend to focus on the physical aspects of ergonomics, but I feel like there's a lot more to it than that, especially like, cognitive team ergonomics. Can you sort of talk a little bit to our audience about what those things are and maybe some other things that kind of fall into this realm of ergonomics that maybe they don't always consider?
Yeah. I mean, from the cognitive standpoint, it's like, yes, you have mental strain that goes along with it. And I mean, that's a lot of what we do is focusing and things along those lines. And it's not just again, most people think about ergonomics, they're thinking about the gross things like, oh, your wrists, your back, things along those lines. Can I pause for one quick second? Okay. Sorry.
Absolutely.
Jason, we really jinxed you.
I know.
Sorry, I just had to take my ergo break. I'm just kidding.
Oh,
No, I'm just kidding.
that's actually
Oh, your ergo
perfect.
break. That was great. I love
You're
it.
right. That's 30 minutes. Yeah, that's actually, we're keeping that in.
Yeah. Well, we should all take an ergo break.
Yeah,
Yeah,
we're
we should
taking
Yeah,
all
we
an
should all
ergo
do
take.
break.
it
I mean, we've
Everyone's
been
going to take an
sitting
ergo
here.
break.
I
make
mean,
sure you're
Kevin, I
wearing
don't want
pants
you
on
to
Zoom,
throw out another, disc or something like that. So,
It's been a couple years, so I should be good. But
okay.
yeah, you're right. I just stood up for everybody listening. I stood up, took a 30-second ergo break, and we're
Yeah,
back
stretch
at
the
it.
legs out. So I mean, I think where you're getting at, Jenny, is towards the things like cognitive load and things along those lines. Because yeah, we think of ergonomics usually about gross motor function, like okay, carpal tunnel syndrome from repetitive wrist motions. You're thinking about back pain. You're thinking about shoulder pain. You're thinking about these things. But I mean, it goes much further. It's like you can get eye strain, you get mental fatigue. When you're in an environment where, it's dark and you're looking at certain contrasts of coloration and intensities of light. I mean, these are all other aspects to your work environment that sometimes aren't just the first things that people think about. I mean, it's really about the entire workspace and human factors. So, maybe there are things such as reflections in a room or the acoustics in the room that are actually indirectly related to your work environment that can affect that and can cause other sorts of strains. So, I mean, again, we're looking at some of the gross and sort of typical types of things of repetitive motion, but really it comes down to the entire environment, and all those things come together in their own components. So, like an example of how I try to mitigate those types of things is like, yes, a lot of people like to have, music or background noise, but at some point there is a diminishing return. So you do have to be careful about the auditory environment. And recognizing how much is too much, are actually speakers placed in weird locations in your rooms that actually cause more acoustic, echoing and things like that, that makes it hard for communication. Lighting positions and how reflections off of walls or instrumentation can affect your visual field. So I'm not sure if that's kind of what you're getting at, but all these things come into play when we talk about ergonomics and human factors. It's not just your typical things.
Yeah,
So I
that's
think
totally true.
I
Oh,
think that
I
was
was just
a. Oh, go ahead.
Sorry. Well, I was just going to say that I feel like, there's been this concept of this ergonomics timeout too, where you sort of talk about all these factors. And I think people have even started talking about, OR interruptions as part of the cognitive disruption
Mm,
that you have during a
yeah.
case, especially like, if your team changes over when you're in the middle of something or you're really focused on a hard portion of the case, and maybe even like during the timeout to say, hey, like, there are certain parts of the case that would be great if people didn't take breaks or we didn't have team changeover, and just really getting everybody on the same page, not just physically, but also sort of mentally. So I think it's really kind of cool to think about because these are things that we feel like are just automatic, or maybe we do them or don't do them. But I definitely think it's worthwhile being pretty intentional about it. So that's awesome that we get your expertise on that today.
Oh, absolutely.
Yeah, I mean, I think this was like a 15, 20-minute primer on surgical ergonomics that, can be referenced for years to come, especially as we shift to, changing the ways that we do surgery, whether it's shifting from lab to robot, to endoscopic. I think these are huge, principles for us to keep in mind. So let's shift a little to education because this is clearly a huge part of who you are. You were the residency program director at UNM for 5 years. You've been the vice chair of education. Within SAGES, you've been involved in the fundamentals programs, FES and FLS, endoscopic and laparoscopic surgery. What drives you there in the field of education?
Yeah, my mother was a university professor, so I think a lot of the teaching comes from that. She was a sociology, behavioral science professor, and I could tell that, one of her biggest joys was watching her students succeed and being able to, impart knowledge on another generation. And then specifically from a surgical standpoint, one of my mentors who I, owe so much to, Dr. Nat Soper, he was my chair at Northwestern, a huge mentor, advisor for me. He told me one thing, and I remember this very vividly. He's like, as a surgeon, you can do some sort of finite number of operations every year, whether it's 300, 500, name your number, but you have a finite number of cases you can perform, and that's a X number, limited number of patients. But as an educator, if you are able to, add something to some other surgeon's technique, you're teaching them something else. And if I'm able to do that with 5, 6, 7 residents a year for multiple years, all of a sudden your ability to help patients becomes exponentially increased. Again, it's kind of like what are you able to really share with the entire community? And to that, and that's really stuck with me. I mean, again, I respect him immensely as a surgeon and technician, but he's taught me things that now I'm able to, share with my own residents, and they're sharing with their, future trainees. And again, it becomes an exponential number of patients that you can actually influence. They don't necessarily just have to be operated on by you. And I think that's probably been one of my biggest motivators to stay involved in education. And then the secondary thing is, I love it because the trainees keep you on your toes. They're always asking the inquisitive questions, and if I don't know the answers, then it makes me want to, keep learning more. So it helps keep me up to date with what's going on in modern medicine. It makes me question, well, am I doing things because of dogma or because of evidence or, some combination of both? And it's fine, but it's important to recognize why we do the things that we do. And I think the trainees are a big part of keeping me, learning on my own and staying inquisitive about these things. So I think that's what's really helped, motivate me as like an educator, and that's why it's still such a big part of my career right now.
Yeah, and I understand that you're also a part of helping create the Simple app. I think all of us who teach residents probably have used it. It's the app on the phone for helping give residents feedbacks to the system for improving and measuring procedural learning. Can you
Yeah.
tell us a little bit about that? All of our
Yeah.
listeners have you to thank for filling out these forms.
Well, yeah, we were one of the, I think, 14 or so residency programs when the Simple app was first coming out. It was, a multi-center study, probably about what, 12 plus years ago now, where we're looking at ways to assess resident autonomy, both from the resident perspective as well as from the educator's perspective. And um, and giving that feedback in real time and then using it as a longitudinal way to hopefully identify that people were making progress throughout their training. I mean, it's one thing to tell a trainee that, yeah, they're doing great, that, nice job on your operation, but really to provide constructive feedback and also to give greater levels of autonomy based off of their performance. So that's kind of what the impetus was way back when we were all part of this multi-center trial. And, we got great data about it. And the fortunate thing is there was a lot of congruency between resident perception of autonomy with educator perception of autonomy. So they did follow each other. Now, they weren't necessarily the same number. Somebody may have thought, oh, I'm doing everything completely, without any assistance. And the attending's like, no, I actually provided a lot of supervised assistance. But at least the trends were in the same direction. So we knew that there was consistency there. And ultimately, based off of, the thousands and thousands of cases that we recorded it for through the multiple institutions, through the multiple training levels, the ABS is, or, has, I should say, or the ACGME has adopted it as the way to help look at resident autonomy and performance of procedures throughout their residencies. And it's great to see something like that, which started out as a very simple, like, I know it's called simple, but it is a very simple mechanism and tool to actually provide substantive, quantitative, and constructive feedback to trainees. So,
Yeah, that's great. It's clearly what a lot of faculty are using since it's a board mandate now. And you did write about resident autonomy, kind of alluded to it, and I'm going to maybe ask a similar question I asked about ergonomics because it's nice to have some practical, uh, you know, pieces of advice for our listeners. So, how can we, as faculty, provide better autonomy for residents? I can tell you the Simple app is pretty basic and it just is kind of a post hoc uh, tool. So, what is something attendings can do in the OR, maybe tomorrow?
yeah,
They want to provide better autonomy for the residents.
sure. Well, I'll take one step back and say, it's very dependent, of course, also on the level and experience of the trainee, but also the level and experience of the attending or the teacher as well. So I think first you have to identify where you are and where the trainee is also in their skill level. But there are always opportunities to provide some autonomy, regardless of if you're a junior faculty or a senior faculty, and if they're a junior resident or senior resident. And I think the best way to, at least in my mind, that I'd like to try to establish that is actually before the case starts. I try to ask them what, as a trainee, what do you want to get out of this operation? What part of it would you like to, do? And if, they're a PGY one, they're like, oh, I want to do the entire hiatal dissection and everything. It's like, no, you're probably not there yet. But let's talk about other things first. Well, what's your experience with placing trocars? What's your experience using certain types of instrumentation? Have you ever done XYZ portion before? And based off of that feedback, I could say, okay, well, during this operation, I'm going to give you the opportunity to do this part of the procedure. Uh-oh, am I locked up? Did I freeze for a moment, or can you still hear
No,
me?
you're good.
Okay. All right. Yeah. So again, I kind of stayed up front with them. I'm going to let you try to do this portion of the operation. And if you struggle, then I'll probably need to take it over. If you're able to accomplish this, maybe I'll let you do the next step or, something a little bit more advanced. But by establishing that baseline at the beginning, I think it sets the expectations for the learner so that they know they're going to get something out of it, even if they're not doing it skin to skin. So I think when you establish that, and then at the end of the operation, to make sure that they were able to accomplish what they had determined that they wanted to do during the operation, I think completes that circle and really emphasizes to them, like, yes, I actually did do, some aspect with some level of autonomy. So, really making that pretty clear, I think, has been something that I think is something that's very easy to do. Whether it's at the scrub sink before you actually scrub in, or, the time in between the cases, or if you're debriefing with your trainee the day before, like, hey, we're doing this case. What do you want to get out of this? Okay, then let's have you try to do that. If you accomplish this, I'm going to let you do this. And then making sure that at the end of the operation that you were able to achieve those goals and, what were their learning points from it.
Probably a good time to do a nice plug for the Train the Trainers course and the SAGES very, very successful program to teach adult learners with this kind of set dialogue closure framework.
Mhm.
For those who have an opportunity to take it, I highly recommend it. It really helps you come up with a format to really be more structured rather than just kind of like watch what I do and then do it. And so I know that you're a veteran of that program, and based on what you're saying, it clearly plays a role in your OR. I do my best. I think a lot of us basically have these commiserating sessions where we're like, I do the set, but then the dialogue comes and I just take over. And, so it's not like an all or none thing. You can do some components of it and try to continually get better. But I think anyone who has an opportunity to do the Train the Trainers course should jump on it.
Absolutely. Fantastic course, even if you're a senior faculty member. I mean, I only took it just a few years ago and I got a lot of out of it. And it's really helped me just kind of, like I said, verbalize things, and it makes things a lot more clearer, I think, for the learners as well.
Yeah, I totally agree. I feel like it's also really nice as a junior attending because I took it a couple years ago. Because I feel like when you first come out and you're a junior faculty member, you realize that transition from, being a trainee to a teacher is a really hard one to make because nobody teaches you how to teach. And then I think it does, like both of you have said, provide a really good framework for how to approach the teaching. And just like Kevin said, I think sometimes it's nice to have a refresher. It's nice to kind of think about things that you do well and things that you're continuing to improve on. It's definitely part of the learning process. Okay, so I'm going to pivot a little bit and I want to talk to you about Japan. So, from your CV, we know that you've been a visiting professor at Osaka University multiple times. It sounds like you've been there um, almost like every year, every other year for the past, 10 years or so. And so, what do you want to tell us a little bit about your experience, what you do
Sure.
there when you're a visiting professor, the connection that you've built there? We'd love to kind of hear a little bit about that.
Yeah, absolutely. Yeah, so one of our emergency medicine faculty actually is originally from Japan. He trained there and then he came to the University of New Mexico and repeated his residency here. So he developed some relationships with his home programs. And the emergency medicine system in Japan is probably where the US was 30, 40 years ago. They're still developing EM residencies in the sense that the way that we know it now in the US. So interestingly, a lot of the emergency medicine physicians in Japan are actually surgeons. They're orthopedic surgeons, neurosurgeons, general surgeons, because they do take care of trauma and acute care as well as other things, and they do their own procedures as well. So while a lot of our EM faculty were going over and teaching some of the more traditional, okay, acute coronary syndrome, stroke management, things like that, their surgeon or their EM faculty there wanted to learn more about the procedural side of things. So what do we do with acute care surgery and trauma surgery? Because they had to take care of those things too. And of course, in the US system, trauma surgery handles the operative sides of trauma. We do the admissions and we do the sort of post-admission care and everything, which is, again, different from a lot of places in Japan currently. So I kind of went over there initially because of that trauma side of my career, but also they wanted to learn other aspects about acute care surgery, GI surgery, surgical education, how the systems are different compared to the US, et cetera. So yeah, I started doing that back in, wow, it's probably almost 2017 or something, and pretty much annually other than during the COVID years. Travel got shut down and whatnot. And I go there for a couple of weeks at a time. Osaka University is a huge hospital system, so there are many sort of small training programs within Osaka University, multiple hospitals. So I kind of go between about 4 to 5 different hospitals providing didactics. I do skills labs. I do traditional like attending rounds where the residents will take me around, see patients, and try to present them. And it's an opportunity for them to learn and practice medical English. It's an opportunity for them to learn about the US sort of healthcare system, our styles of patient treatment. It's very interesting for them when I tell them, oh, yeah, we do elective lap choles, we send them home same day. And they're like, what do you mean? We'll still keep them in the hospital for a couple days, but then they don't prescribe narcotics routinely for their patients. So postoperatively, if they're going to get any sort of narcotic pain medication, it has to be it is inpatient. They only get discharged with small doses of ibuprofen and Tylenol. So it's like kind of
I mean,
understand.
I always love reviewing their gastrectomy papers where it's like a laparoscopic gastrectomy and the average length of stay is 17 days,
Yeah,
and it's like
exactly. Like, whoa.
and it's better than open, which is 20 days, and you're like, was it though?
But you're
But you're
like,
right, it's
wait a
because they
minute.
don't.
Why was it 17 days? It could have been, less than a week here in the United States. But again, yeah, there are sort of systems for dietary advancement and expectations for postoperative pain. And again, what they prescribe to them. I mean, they don't have the opioid problem that we have in the United States
Yeah,
because they don't
yeah,
prescribe them, right? So
yeah.
there is that side. But the flip
So
side
what do
is,
they use for post-op pain control? Now I'm kind of curious.
I mean, if you're in the hospital, yeah, they'll give you opioids, but rarely
They
do
don't
patients
send you
actually get
home.
discharged with
Oh, they don't
anything
send them
other
home with
than
opioids. I
Yeah,
see. Yeah.
non-narcotics. Yeah, yeah.
Yeah.
I mean, I had a colleague or I had a friend who broke his arm in Japan while just visiting, and they discharged him with like high dose ibuprofen, and he had a complete fracture, and they casted it, but like you know,
yeah.
have fun for a few days, you fly back to the United States, sort of thing. So their perspectives on opioids is a lot different, and their hospital length of stay, again, it's much different.
I'm sure that it is kind of cultural too, because I think it's probably similar in China because I think people expect to be hospitalized and stay. I think
Yes.
they feel like
Mm,
it's weird to have outpatient surgery.
Right.
So I wonder if there's some sort of a cultural difference. And I think we see that in certain countries in Europe too. I always find it really
yeah,
interesting when I'm reviewing manuscripts
Mhm.
and papers that come from different countries, because a
Yes.
lot of times what you think, what you're so used to here is maybe completely different somewhere else.
Yes. Like you said, Kevin, it's like hospital length of stay was 17 days, but post-discharge narcotics use was zero, right?
Because they
you're
use
like
it all
what?
in the hospital.
Yeah,
Right.
exactly.
You know,
Yeah,
so like understanding that side of things has been, very interesting.
yeah,
Understanding their educational system and, how they do it differently from the United States has also been very enlightening. They do more
yeah.
of the combined, it's more like European style. They do a combined 6 year coming straight out of high school.
High
And
school.
then
Yeah,
they do 2 years of a general residency before doing the formal specialty training, which is the same duration as the United States, essentially. So by the time you finish, it's about the same, but they do officially gain the title of physician about 2 years earlier.
mm,
But I will say from the surgical perspective, it's interesting because I think overall our residents get a lot more autonomy and they get to do a lot more cases compared to their Japanese counterparts. I mean,
Yeah.
watching how they work in the operating room, it's a little bit more traditional as a whole again. And things are starting to change, but still a very traditional hierarchical system. You know, there are cases where double attendings are doing cases where normally you'd see an attending and a resident here. You know, what they're allowed to do and what their required case numbers are different from the United States. So they hear that like, hey, I'm doing this, you know, trauma operation in the middle of the night with the fourth year resident on night float, and they're like, what do you mean? Shouldn't you also need the vascular attending and a second attending? And I'm like, no, this is different here. So and as part of it, you know, they're very interested in about the US system. So we've got a partnership program where their students, residents, and attendings will actually come to the University of New Mexico as well to do observership. So I just had two students in their last year of medical school spend about a month here in Albuquerque, spent some time with emergency medicine, spent a couple weeks with us in surgery just to kind of, you know, see how we do things. And they're like, oh yes, it's very different here. And I'll say the residents get very envious of what our residents get to do. So when we talk
I'm
about
sure.
autonomy, and
Yeah.
when our residents say, "Hey, I didn't get to do enough of that operation," I'm like, "Well, in
Go spend a
Japan,
week in Japan. Yeah, and
yeah,
you'll see what,
exactly. You
yeah.
know, see what your counterparts are doing. Maybe you're just closing skin as the senior on that case, as opposed to, you know, letting you do the dissection and, you know, do the stitches of the fundoplication or whatever else. So it's been cool to see the different systems and how, you know, the healthcare systems work and whatnot.
It
So
sounds
yeah,
like you gave a keynote there in 2024 about improving work style and treating acute care
yes,
surgeons well.
yes,
So that's a wellness message to a Japanese audience from a US surgeon. That's quite
yes,
brave. That's a brave
yeah,
yeah, brave topic.
yeah. So again, they're still very traditional in the sense that, you know, it's hierarchical. The demographic of surgeons in Japan is again kind of probably where it was in the United States decades ago. And, you know, while there are duty hours and things like that, you know, the enforcement is not the same as it has been in the US, especially recently. And one of the things that they're finding is because of some of the aspects of whether it's harassment um, or like extreme fatigue and things like that, that they're finding that their medical students are not as interested in going to surgery in Japan as they would be going into other fields. And especially with the way the healthcare systems work, it's nationalized healthcare. So physician salaries aren't based on specialty. It's pretty much relatively uniform, regardless if you're family medicine versus a neurosurgeon. So people are like, well, why would I want to spend 7 years in a neurosurgery residency, have all these, you know, liabilities, stress, etc., to be compensated at a similar level as somebody who's got a purely outpatient clinic type profession? And to that end, they're finding the number of students going into surgery is decreasing. And in fact, they are at I mean, we think in the United States, we've got problems with not having enough surgeons, especially in rural areas. I mean, Japan has an even bigger problem. And especially based off of their aging population, they are going to encounter a major problem. And
Wow.
some of my colleagues out there who've experienced, you know, different healthcare systems, whether it's United States, Europe, Africa, etc., recognize that it is a problem. And they asked me to go out there because, you know, at least it's coming from somebody not from their own country. This is somebody coming from the United States who's presenting, you know, factual data that they have and trying to provide a different perspective of like how have we changed our work environments to make it more conducive to learners, to encourage people to want to go into surgical fields. And they are in a situation where they are not there yet, but there are enough faculty, both junior and senior faculty, who recognize it's a problem and want to start changing things. So we talk about things like advocacy with their government system. We talk about how do you just improve the treatment of your own trainees. I mean, you know, the stories I hear sound like the stories that existed before even we were trainees, or, you know, maybe at the beginning of my training, things were still of that perspective and mindsets, things that, you know, would not be acceptable in today's work environment still go on over there on a routine basis. So without changing things, their country is going to have a problem with surgical healthcare delivery in the next couple years. I mean, it's already started. People are dropping out of the field to switch fields. People aren't going into it. And as you know, there's a lag time from training until people are ready to practice. And they don't do something soon, there's going to be a problem.
Yeah. There's problems all over the globe. Let's put it that
Yes.
way.
Every place has got their own
Yeah.
problems.
Yeah.
And, it's like which are the ones that, different types of environments and political structures and governments and health systems want to, work with. But access to care is a problem in many parts. It's just why is there an access to care problem that I think is becoming a situation for at least Japan. Mhm.
All right, so we promised some fun stuff too for our listeners. So we're gonna move into the Star Wars slash anime this
Oh,
segment.
goodness.
So
Okay.
so what's your Jedi versus Sith call? Are you a Jedi or a Sith? May the Fourth or May the Sith?
You know what? And I think my family would back this up. Yeah, I'm a Sith Lord probably,
You're a
but
Sith
there's
Lord.
but there's still good in me.
Ah,
I say that I'm like the
ah.
Kevin
Anakin
thought you were a Jedi.
I
Skywalker.
thought you were a Jedi. I
Well, so
thought.
here's the thing, right?
Okay.
Like I'm probably the Anakin Skywalker, Darth Vader. There's still good in
Ah,
me.
okay, okay. You just need to be redeemed.
Yeah, but
You need
and
to
it's
you need to almost die before you're
something like that. I mean, like when I
okay.
went to Star Wars Galaxy's Edge, yes, I picked a red kyber crystal to make my lightsaber. So, both my
Okay.
boys, they chose blue and green. Yes, I chose the red one.
Mm.
Um,
So do you apply any of this Sith or Star Wars philosophy to surgery?
I don't force choke my trainees,
Okay, that's good.
right,
That's good.
right. But I would say that I do have high expectations, and some of that probably comes across in that Sith way. But w without, I mean, I say that, but I don't know. It's like, so I'll show you my ID badge, and people can't see this. Yes, I actually have a Yoda on my ID
Aw, so
badge.
you're
Okay.
secretly a Yoda. You're a
Okay,
Sith
all
Lord,
right.
but secretly a Yoda.
So,
Secret.
it's like,
Maybe not so secretly.
I don't know if I'm secretly one way or the other. Is like, I feel like I
You're definitely
understand.
torn. I can
I'm
sense
torn.
the yeah, I can
Conflict.
That's
sense
why I
the
consider
tension.
myself like an Anakin. Like, you know
And
what?
Anakin.
He
Yeah,
became
yeah.
a Sith Lord because of love, right?
Yeah,
You actually
yeah,
follow the
yeah.
storyline,
Yes.
it's all about love for his partner that actually
Mm-hmm.
took him to the dark side.
Yeah, yeah,
It wasn't like
yeah.
malicious intent. He's not out there as like, I want to kill her. He's like, I want to restore balance and
Yes.
that sort of
Bring her
thing. It's
back.
just the
Yeah.
way he did so got convoluted because of a mentor. So,
Yeah.
like I get it from that perspective, and maybe I'm not the like I will be patient about every single thing. I'm probably actually more patient with my residents than I am with my kids. So so maybe I'm more of the Sith Lord at home and more of the Jedi at work. How about
Okay.
that?
That's fair. That's fair.
Because yeah, my work people would say, "What do you mean?" I'm like, he doesn't raise his voice, I don't do any of those sorts of things. So um, yeah, it probably depends on the situation. Tiger Dad, Sith Lord. Yes, Jason.
Tiger
That's a
Dad,
good way to
Sith
say
Lord.
it.
Yeah,
That's
Tiger
probably what it
Dad,
That's
is.
Sith
the name
Lord.
of this episode, Tiger Dad Sith Lord. Jason, remember that when you add it to Spotify and the podcast, I feel
Darth
like it
Darth
would
Tiger, Darth
Tigress.
Tigeris. Yes.
Darth Tigeris. Oh, that is your new Sage's name. I love it. You'll have to print it on your ID badge
There
Yeah,
we
next.
your
go.
badgeness.
No longer Pappy Van Winkle.
Yeah. Well, so tell us about your interest in anime. Do you do
Sure.
anything when you go to Japan? I feel like that's kind of the homeland of anime. Do you have anything that you
Um,
love to watch or anything in particular
so let's see
that
here. I am a fan of the One Piece series. If you haven't seen that, it's been going on for what, 20 years? I think it's probably one of the longest standing mangas that's out there. I mean, the themes are adult as well as, consider a children's audience, but I think the storylines are very good. Character development's excellent. Anime is solid also, but it's got a lot of character development, which I really appreciate. So that's one that I enjoy. I enjoy Demon Slayer, another one. I think the characters are getting really well done. Maybe a little bit violent for those who have young kids and things like that, but at the same time, just really good character development, I think is the thing that I appreciate out of those two. So those are probably my two go-tos. There are characters that I feel like the thing that people enjoy about whether it's TV series, movies, etc., is that sometimes there's a character that you can kind of associate with, and I've
You really
found
relate to.
characters in both of them that I feel like, oh yeah, that's kind of, a little bit my personality in different ways and everything like that. So, yeah, and then when I go over there, I admit I like to collect memorabilia and things along those lines. So it's kind of fun to find, Japanese exclusive things. I've actually found I still have my original Star Wars toys from when I was a kid back in the 70s. And when I've been over in Japan, I've found vintage Star Wars action figures with Japanese labels on them, which is actually pretty unique. And I'm sure some of them are probably worth a substantial sum now. But, I enjoy doing a little bit of treasure hunting from that standpoint when I go over there. And then
So
the
if you were,
Japanese cars, I think are really cool.
oh yeah, for sure. So if you were transported to a fantasy world, one of these anime worlds, what would your surgical
Ooh.
superpower be?
My surgical superpower?
Yeah, yeah.
I was
So
gonna say a
you're now
superpower. I've always wanted to just be able to fly. Like people ask me
okay.
what
All right. Well, that's
superpower
good
in
too.
general. Like I wish I could fly. Surgical superpower. Wow.
Like you're a surgeon, you're an anime surgeon. You're the one that's gonna like save the hero, you know.
Probably to be able to just use the force to heal somebody, right?
Okay. Yeah.
You know,
Simplistic
I
like
love
view.
it.
I don't
I love
even
that.
need
Yeah, that's
instruments.
great.
I could just
Just
meditate and just project my chi onto them, and like whether it destroys the tumor or fixes the defect wherever it may be or something like that. Like that'd be awesome.
good for ergonomics.
Good for ergonomics, right?
Yeah. No static postures.
There we go. I
Well,
just wave my hand over somebody and things happen.
Ed, this has been amazing. And so we have one last question for you, and
Okay.
it's our favorite segment of the show, and it's the We Are Sages segment.
We are the world. We are the world. We are the sages. We are the sages. Sing it, everybody. We are the ones who make you brighter days. So let's start treating. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are dancing.
So thinking back, as a Sages member, in all your years at Sages, do you have a favorite Sages moment or a Sages story?
Um, I'll say when you mentioned that, the first thing that sprang to mind was maybe probably Sages, was it Baltimore around 2012, 2013 or so. The Sages Sing Off is one of those things that's not replicated at any other surgical meeting out there. And I think that's probably one of the things that, attracted me. It's like when you get to see your colleagues, your mentors up on stage, just kind of, showing that they're regular human beings, whether they're sharing talents or their lack of talents, it's a lot of fun. And I remember at one of the sing-offs, crowd surfing. And I can't remember what song they were playing or anything like that, but a lot of us from that same fellowship year, I think, I asked people like, hey, raise me up, and they crowd surfed me onto the stage, and I was about to dive off the stage until our current stage's president, Dana Tellem, like waved me off, and she said, don't do that because nobody's going to catch you. But I think that's
I'm sure people would have caught you.
maybe so, but I wasn't gonna chance that, especially as like a first year attending. But I think that was one of those moments I'm like, hey, I don't know that anybody's ever crowd surfed at a Sage's sing off before. So that was definitely a very memorable experience for me.
That's awesome. Well, Ed, on behalf of our listeners, who I'm sure will be bookmarking this one, and we'll certainly put some key topics in the show notes. We'll put some links to some of the ergonomics videos that have come out from your task force. I think those have been great. Obviously, FLS, FES. We didn't get a chance to hit all of your loves, but I think we got a nice little sample of just how special you are. And I just want to thank you for a great episode. And to our listeners, if you enjoyed this episode, leave us a review, share it with a colleague, and keep checking back for new episodes each month or so, about each month. So thanks, Ed.
Thanks to both of you for inviting me. It's been a lot of fun. And again, SAGES is my surgical home outside of my university practice. And such a great community to share things, both academic and non-academic. I mean, it's just a wonderful community, and I encourage everybody to just become active with the group and to take advantage of everything the society has to offer.
Well put. Thanks, Ed.
Thank you.
And that wraps up today's episode of Sage's Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.